clapper deformities always have to go to surgery. Let's look at another challenge case. This looks like a torsion. Patient was acutely symptomatic on the right side. Looks like a torsion with an infarction. But 4 minutes later, there's now a hyperemic testis on the right side, and the patient was feeling better. And I followed this patient. 10 minutes later, there was normal bilateral symmetric blood flow. So what was going on in this case is also a patient who had a detorsion that occurred during the ultrasound scan. So it was not an infarction, it was another torsion that had detorsed. And if I only saw this patient at this point in time, I would have had to read out a normal ultrasound study. But 10 minutes earlier, we saw no flow. What should happen to this patient? You've got to get on the phone, call the clinician. This patient needs to go to the operating room shortly thereafter the study to evaluate, as was noted in this case at surgery. There was a bell clapper, and this had to be fixed clinically at surgery. And as a word of caution, whenever there's a bell clapper on one side, the other side has to be surgically looked at, because very commonly there will be bilateral bell clapper deformities, as was the case here. So this was a very fortunate man. He was able to keep both his testes, and we happened to see the torsion that detorsed. So testicular infarction, the first indication or the primary reason why people have testicular infarction is torsion with a bell clapper. Other times when you can get testicular infarction, although not nearly as common, so smaller letters would be post-orochitis and sometimes post-surgery. Let's look at a couple of cases. Here is a patient in whom clinically there was symptomatic epididymal orchitis on the right side. And on this particular date, there's increased flow going along with the known epididymal orchitis. So the right side is the symptomatic side. Now, about a week later, we looked at the same right testis, and there was no longer blood flow, comparing it to the left. Always when you're doing a comparison, start on the asymptomatic side to set your color parameters, and then look at the symptomatic side. So clearly asymmetry, no flow, heterogeneous. This was an infarcted testis. This was the person I showed you who had the air in the hydrocele, and he had infarcted his testis and had a very bad outcome requiring surgical removal of this testis. Now, what about this case? Left side was symptomatic, no blood flow, and often when there is an infarction, the testis is somewhat more heterogeneous. The tunica albuginea becomes a little more prominent, as does the mediastinum, because of the conspicuity of the heterogeneously hypoechoic testis. Well, what was going on in this patient? I asked him. I was surprised to see this. He said he had had surgery a month earlier and had a hematoma that had developed in his groin. So I went up and I looked at his groin, and he had this resolving hematoma. And I said, "Didn't you have a lot of pain at that time?" He said, "Yes, but I just had hernia surgery, and since I was post-op, I thought that my pain was all post-op." Well, his problem was this hematoma compressed his testicular artery, resulted in a subsequent infarction, so this testis no longer was any use to him in terms of function. So that's why I put post-operative as another reason why you can get a testicular infarction. What about these three different individuals? What's going on here? Notice the irregular outline to the testis, somewhat heterogeneous. Notice the loss of the tunica and an associated hypoechoic heterogeneous area. Notice the same thing in this case, loss of the tunica albuginea and a hypoechoic mass. Well, with the appropriate history, the loss of contour definition, it wouldn't surprise you with the history to suggest a traumatic disruption in each of these cases. Now, each of these patients should go to the operating room in an urgent fashion. Number one, to try, if you can, to repair the abnormality. This is actually this case. This could be debrided, and it was primarily sutured, and the patient did okay. So in addition to try to salvage the affected testis, another reason to bring these people to the OR is because failure to do so, some people believe the extrusion of testicular contents may lead to the development of antibodies that can affect spermatogenesis. And a man can render himself sterile by the antibody response to the sperm that is no longer contained within the testis. That is believed by some, but I don't believe all urologists. But this is one of the findings with testicular disruption. Parenchymal abnormality, we've already mentioned. It can be diffuse, as we see in this case, or somewhat more focal, as we see here. The history will help solve what this is due to, but any of these patients who have focal abnormality or diffuse abnormality should probably go to the OR to ensure whether or not there is a disruption at the edge of the tunica albuginea. Here's a lacerated testis. What about extratesticular pathology? We've been mentioning epididymitis, but let's talk briefly about these different entities. We've mentioned hydroceles. We said it's fluid between the layers of the tunica vaginalis where the peritoneum has come down in utero and should be superior, anterior, inferior, but not posterior to the testis. A little fluid is okay. I don't report it, but obviously a large amount is something to report. Who gets these? A lot of people get this. There are many different indications. I've already showed you this very large hydrocele, no posterior involvement, no posterior fluid. Here's a simple hydrocele, here's a complex hydrocele. History becomes important. This could be pus, it could be blood. Hydroceles are unusual with tumors. They occur with everything else, often idiopathic, but not commonly with tumors. Just bear that in mind. Now, sometimes I've seen people have some diagnostic dilemma. Is it a hydrocele? What is it? Because fluid to them, you think of hydrocele, where in reality it's a focal abnormality or a cyst at the level of the epididymis. Most often these are at the head of the epididymis, as we see here in Dr. Netta's diagram, and often because it's a focal area of an abnormality, it can push and displace the testis, as we see here. Can be simple, small, as we see here. You may or may not want to report that. I don't think these small ones need to be reported. Here we can see it's pushing down. It would be a palpable mass in this case, but it is focal. It is not a cyst in the testis. It's pushing against it. Here's a larger one. When we start to see echoes within them, some people would then characterize that more likely to be a spermatocele, but I don't know how you really separate epididymal cyst from one that contains sperm. And sometimes they may even look solid. There'd be no flow here. And sometimes they are solid, and then you might want to think of a sperm granuloma, which often will occur in a patient who has had a vasectomy. Can I tell this from a tumor? Well, if there's no blood flow, it would be very unlikely to be a tumor. Tumors are unusual at the level of the epididymis. They tend to occur more in the tail of the epididymis, but this turned out to be a sperm granuloma. Multiple small epididymal cysts in this case.